Chairman, ladies and gentlemen, surgery of complex neuroblastoma often requires additional procedures. In some occasions, opening of the thoracic cavity is performed. This is the case if the aorta cannot be secured intra-abdominally because of the tumor extension up to the diaphragm. Also, it might occur that the abdominal approach alone is not sufficient for good exposure of the tumor, or finally, there might be tumor in the thorax, either as a continuation or a separate lesion which has to be removed. However, the concern regarding increased operative trauma and morbidity, post-operative pain and complications associated with the two cavities approach is the reason why some surgeons are reluctant with performing this technique. Here you can see one of our cases in which the tumor extends up to the diaphragm. In the sketch below, you see the principle of our dissection technique, which always begins laterally on a tumor-free part of the aorta. The red line marks the diaphragm, and you can clearly appreciate that securing the aorta above the tumor is not possible in this situation. If that is the case, we open the thorax, in this particular case through a thoraco-abdominal approach, opening of the diaphragm laterally by keeping about 2 centimeters of dorsal diaphragmatic margin to avoid injury of the phrenic nerve allows access and securing of the aorta. In general, the decision on which way the thoracic part of the surgical procedure is performed depends on the individual conditions of each patient. The aim of the present study was to evaluate the efficacy of a two cavities approach for resection of pediatric abdominal neuroblastic tumors. To this purpose, proposed charts of patients with abdominal neuroblastic tumors who underwent a two cavities approach were retrospectively analyzed between March 2002 and September 2021. We operated on 232 patients with abdominal neuroblastic tumors. The two cavities approach was performed in 31 cases. The median age at operation was 48 months. 3 patients had ganglioneuroma, 5 had ganglioneuroblastoma, and 23 neuroblastoma. The most midline tumors were the most frequently encountered, followed by thoracoabdominal in 12 cases, thorax and adrenal in 1 case respectively. The approach most commonly used was the transverse laparotomy with incision of the diaphragm, followed by the thoracoabdominal incision. Other approaches used were transverse laparotomy with thoracotomy, laparoscopy with incision of the diaphragm, and transverse laparotomy with thoracoscopy. The vast majority of the patients present image-defined risk factors. Encasement of at least 3 large vessels was encountered in 20 cases. Gross total resection was achieved in 24 patients, a nearly gross total resection in 4. 3 patients had a gross residual disease after surgery. The median duration of surgery was 288 minutes. Median duration of mechanical ventilation was 22 hours. Median length of stay on intensive care unit was 4 days. The patients were discharged from the hospital after a median time of 16 days. The postoperative chemotherapy could be started after a median of 21 days after the operation in patients with neuroblastoma. No patient presented diaphragmatic paralysis. Postoperative complications occurred in 10 patients. Only 6 required surgical intervention, surgical hemostasis in 3 patients, removal of an intra-abdominal hematoma in 1 patient, and suture of perforation of the stomach in 1 patient. A 3-year-old girl with midline neuroblastoma previously operated in another country was referred to our institution for completion of the tumor resection. We achieved a gross total resection, but unfortunately, this child suffered a septic erosion of the abdominal aorta, and despite multiple interventions, this patient could not be saved and died 2 weeks after the operation. After a median follow-up of 30 months, only 2 patients died of disease. The 5-year overall survival was 90%. The 5-year event-free survival was 50%. In conclusion, ladies and gentlemen, The two cavities approach represents a feasible treatment option in children with abdominal neuroblastic tumors, but it involves complex operations and should be performed only by experienced surgeons and only in centers of excellence in pediatric surgical oncology. The two cavities approach allows a good mobilization of the abdominal organs, which enhances exposure and provides access to the entire vascular anatomy of the retroperitoneum, facilitating a safe and a complete tumor resection. Although the operations performed were very complex, the complications were organ-specific and not related to the approach itself. This approach is very well tolerated by the patients with no added morbidity and no delay of postoperative treatment in patients with neuroblastoma. Thank you very much for your attention.